All right, well, good morning, everyone. Thank you for joining us for our latest media briefing on important healthcare issues in the news. Happy back to school day for many of you on the call. I'm Dr. Kassam. I'm a physiatrist in Toronto focused on musculoskeletal and neurological rehabilitation. I'm also the president of the Ontario Medical Association, which represents 43,000 physicians and medical students. Our children and young people are headed back into school this week, and fall and cooler weather are just around the corner. That means we'll all be spending a little bit more time indoors where we know the COVID-19 virus spreads more easily. The highly contagious Delta variant is driving up infection rates and fueling the fourth wave. Too many people, unfortunately, are still ending up in the ICUs. And that's why it's so important that we continue to remain vigilant and continue to follow the public health measures we have all become so familiar with. Masking indoors, regular hand washing, and good ventilation are some of the ways that we can avoid the spread of infection in schools and other indoor settings. We want to make sure our kids can stay in school with their friends, learning and growing. It's essential, not only just for their education, but also for their mental health and social development. We don't want to have to go back to more restrictions or another lockdown. I believe we can do this. This is the last mile, that last kilometer. And the single most important thing we can do as a society to curb the pandemic is to ensure that we all get vaccinated. About 16% of Ontarians 12 and older are still not fully vaccinated. Modeling shows us if we don't soon get to 90% of Ontarians fully vaccinated, we may risk many more months of these brutal waves of infection. Immunization rates among adults will have a direct effect on keeping children safe. It's also critical that our teachers and education workers are fully vaccinated. No one wants to see our young people suffer from the effects of COVID, and in the worst case, fighting for their lives on ventilators in the ICU. A new analysis of vaccine hesitancy by the Public Health Agency of Canada tells us that there is a sizable chunk of our unvaccinated population, what we're calling the movable middle, who can be motivated to get the vaccine. Some young adults, for example, mistakenly believe that they don't need vaccines because they're at lower risk of serious complications. Others, who may be in their childbearing years, fear what the vaccine may mean for their fertility. We're here today to talk about what we can do to push our vaccination rates even higher and reach those who we believe can be reached. Doctors are reaching out to unvaccinated patients to talk about what's holding them back, and public health units have also been working to remove barriers to vaccination. So, what more can we do for a safe back-to-school season? How can we push vaccination rates up to the 90% mark this fall? I'd like to introduce two of our very esteemed guests who will help answer these questions. Dr. Lawrence Lowe is the Medical Officer of Health for the region of Peel. Before that, he's worked at the Public Health Agency of Canada in the Vaccine Safety Division at Fraser Health Authority in British Columbia as Medical Health Officer for Burnaby and the Tri-Cities, and as Senior Medical Consultant to Ontario's Chief Medical Officer of Health. Dr. Constance Nasello is an obstetrician and gynecologist in Chatham, Ontario. She serves as the chair of the Ontario Medical Association section on obstetrics and gynecology, and is also the president of the Ontario Society of Obstetricians and Gynecologists. Dr. Lowe, will you please start by telling us what we can do to stay safe and avoid large-scale lockdowns this fall as our children gather at school, businesses begin to reopen, and we all move back indoors?
Thank you so much for that introduction and for the welcome, Dr. Kassam. And it's also a pleasure to be here with Dr. Nasello and with all of you this morning. And today, for many of us in the large school districts within Ontario, with the return to school, we know that this marks a significant milestone in the life of our community this year, but also as we move through this end phase of the acute part of the pandemic. There is a recognition, especially with the return to school, that we are not necessarily in the exact same position that we were during the return to school in 2020. Throughout the province of Ontario, we now have over 75% of our residents, vaccinated with 2 doses of vaccine, and we also are now in a situation where we are more open than we have been at any time since March 2020. And all of this really behooves us as we move through this, through the fall, through the reopening, to really look at what we can do to maintain our progress and to ensure that we push through to the final parts of the acute phase of the pandemic. And really, it starts with 2 things. Last week, the Ontario Science Table released new modeling that suggests that what ultimately happens with this fourth wave is in all of our hands, and it's in our arms. And the first is really around vaccination. Vaccination is the cornerstone that has really started to decouple the link between infection and severity. We're seeing it with the current levels of infection that we have right now, not necessarily translating in the same proportion to hospitalizations and mortality that we have seen previously, despite now having been in step 3 within the province of Ontario for almost coming up on 2 months at this point in time. We do know, however, that the vaccines and the coverage that have been distributed to date have not necessarily gotten to some of the hardest to reach or more vulnerable people. And that's why the vaccination strategy for many health units, together with our physician partners in primary care and our provider partners in pharmacies and in hospitals, are moving to essentially work on a more focused, micro-targeted mobile strategy, essentially expanding a lot of the outreach offerings that we previously had in order to try to get out into the community. But it goes without saying that vaccination is the cornerstone to essentially ending the acute phase of the pandemic in our community, because ultimately the virus will cease to be novel when enough people have been exposed either through an immunization or through infection, at which point a novel coronavirus is no longer novel to our population. But that really speaks to the second part, because we do know as we implement these last mile strategies that there are still many individuals who have not yet had the opportunity to be vaccinated, who may have very valid questions or concerns that deserve to be listened to and that deserve to be treated with empathy and respect. And so at this point, it is also about trying to reduce our contacts as well as we can to avoid a large-scale lockdown and to ensure that businesses can stay open, and more importantly, that the children that are returning to school today can remain in in-person learning with confidence. So, certainly there are other measures that people can take in terms of avoiding large gatherings, making sure that they're masking in indoor public spaces, and continuing to do so when the vaccine certificates are released. That will also help to really limit risk for individuals in settings where those measures can't be consistently maintained. And then, of course, other measures such as continuing to engage virtually, whether for work or for at home. Ultimately, keeping our children in school and keeping our progress moving forward in exiting the acute phase of the pandemic requires us all, for the time being, to reduce our contacts somewhat while we move to vaccinate more and more people in this final phase. And ultimately, it's all in our hands to make that happen. So I'm looking forward to the question and answer. I'll pass it back to you, Adam, to introduce Dr. Nacella.
Thanks, Dr. Lowe. And what's really important about many of the things you just said is being able to have that destiny in our arms, that we have that ability to really control our fate now. And I think that that's part of all of our big push here in the final last kilometer. Dr. Nacella, over to you. Are you getting questions from women about the implications of the vaccines for fertility? What are their concerns? What are you telling them? What does the science say? Maybe you can walk us through a little bit of that information.
Okay, well, I think that what we're seeing now is a lot of still hesitancy about getting the vaccine into the arms of pregnant women. And, this is a constantly evolving group. It gets bigger every day. There are 147,000 babies born in Ontario every year. So it really is 147,000 women that are at risk for the very severe consequences of the COVID virus. So what we found, we were able to move the dial to get the medical officer of health and the vaccine task force to allow pregnant women to get the vaccine in the first place and to be able to make the choice to do so. And at that time, we weren't seeing a lot of COVID in pregnant women. We were seeing some sporadic cases. However, we all are very aware of what happened in the spring in the large teaching facilities in downtown Toronto. Mount Sinai, their entire ICU was filled with pregnant women. Over 30 at one point. And the consequences of getting a COVID infection during pregnancy are magnified about 5 times what it would be when you're not pregnant. So, and that's because pregnancy itself is an immune deficient state. If it were not, we wouldn't stay pregnant. Our body, our immune system would identify this foreign material that's growing in our uterus that's only half like us as an invader, which kind of technically it is. And it would eliminate the pregnancy, much the same way that antibodies eliminate an invading virus. We also know that there is a lot of variability in early pregnancy. Up to the age of about 30 to 35, there's the risk of miscarriage is about 15%. So that means that every woman that gets pregnant has that risk. That's our background rate. And as women get older, our eggs frankly get older as well. And the miscarriage rate actually increases starting at 35 and annually increases about 5 to 10% up to the age of 40 and 45. So the miscarriage rate is very high if you happen to be over 35. And that is a lot of our pregnant women these days. The other issues that each woman needs to consider for themselves is what is the data on the safety of the vaccines? We all know they were not tested in pregnant women, and that is a defect in the vaccination testing programs that obstetricians and gynecologists and our various societies around the world have been trying desperately to change because we don't know what the outcome will be in pregnant women until we have tested it on them or exposed them. Now, what's different about the messenger RNA vaccines, which we have recommended for pregnant women, is that there is no virus. The messenger RNA is like sending your cell an email. And when you open the email, it tells your cell, well, get your act together. I want you to make this product. And then you delete the email. So that really, in a nutshell, is how the messenger RNA vaccines work. And I think it is also phenomenal that messenger RNA vaccines were developed here in Canada by a female scientist. So, and this is, COVID is not the first virus it's been used against. This technology was used for a number of other viruses that were very virulent but short-lived, particularly the Ebola outbreak a couple of years ago. And they were able to resolve it by using a Canadian-made Ebola vaccine using the same technology. So I think it's important to understand that with the vaccine as well, there are exceedingly few people that actually have an allergic reaction to the one product that has the potential to cause that, and that's polyethylene glycol. So polyethylene glycol for the average person is actually the main component in many of the products that are used for constipation. They're used in children, they're used in adults. It also is one of the filler components in almost every pill that is on the market. So it's impossible to not be exposed to polyethylene glycol. There are a few people, as Dr. Lowe and Dr. Kassam have mentioned, that do have a true allergy. But even that group of patients that have had an allergic reaction, like an anaphylactic reaction to the vaccination, can actually be given their second vaccine under medical supervision and with medications that will prevent the anaphylactic response. So I think that we have to take that into consideration. Now, specifically looking at pregnant women, Yes, we started out with a huge experiment in pregnancy. And the earliest people enrolled in that study were actually pregnant female physicians, pregnant female OBGYNs. We understood the science. We understood the particular safety of this vaccine, which is now being rolled out to most of the world. In the US, we have data that over 100,000 women have been identified as receiving a vaccine in pregnancy. There are surprisingly only about 4.5% that have enrolled in the post-vaccination surveys. And those are the surveys where we actually identify in larger populations if there is a problem. So that's our post-marketing data. So I think it's really important if women are choosing to get the vaccine that they do so and participate in one of the post-marketing surveys. There is one in Canada out of UBC, and their obstetrics and gynecology department, and you can actually look up that program online, and the survey is free for you to actually write down your experience. I think it is also important to understand that the vaccinations do not cause miscarriage. There, yes, are women that have received a vaccine that suffer miscarriages, but remember that 15% of women who know they're pregnant who are going to have a miscarriage anyway. That can't be teased out from those numbers. It can be given at any gestational age in pregnancy. In the earlier days, people were perhaps a little more cautious because we were, as physicians, well aware that, that women that took a vaccine very early in pregnancy and then subsequently miscarried would be likely by proximity to blame it on the vaccine, when in fact it has nothing to do with it. But that is a personal decision that every woman can make. It is safe, and we have actually known from very early days that the babies that were born of women that received the COVID vaccines actually transferred antibodies through the umbilical cord to their babies. That's the same mechanism that occurs with other vaccines that we recommend in pregnancy, the flu vaccine and the Tdap vaccine, the pertussis vaccine for adults. And that is to be repeated in every pregnancy because those antibodies transfer to the infant and will protect the infant for at least 6 months. A recent study came out in the Journal of Pediatrics, I believe, the end of last week, that has looked at a larger group of pregnant and, postpartum and lactating women that received the COVID vaccines that had uneventful deliveries and newborn courses. And they had antibody levels in the babies, but they also had substantial levels of antibodies in breast milk. It's still early days as far as how effective that is in the infant's gut, but it certainly can provide some protective antibodies to the mouth and the upper airway area. So it's very important for newborns to have that protection, both until they can get a vaccine themselves. And the studies in children are ongoing. And I know a number of female surgeons and OBGYNs that have enrolled their children in these early vaccine studies in the States and a few in Canada. So, we should be getting some very solid information soon in their safety. But having said that, I have to echo what Dr. Lowe said. Going back to school this is a particularly vulnerable time. It's for everyone that has received a vaccine, because if you're in an at-risk population, your immunity may be starting to wane. We are looking at, in the high risk, high priority groups, likely needing vaccines. And I can speak from personal experience. My secretary yesterday got a phone call from her son's new high school that he was exposed to a COVID positive classmate on day one. It really meant a huge sudden shift in my office to switching everyone back to virtual. So.
Well, thanks so much, Dr. Nacella. That's a lot of really important information for all of us to really better understand and hopefully carry forward as we're talking with our patients, but also with loved ones and peers and others. What we're going to do now is actually transition to question and answers. First of all, I wanted to thank Drs. Lowe and Nacella for really your expertise and your valuable insights. We're going to now open up our quick Q&A session with Ryan Joyce from the OMA, who will be moderating this portion of today's briefing. Please put your questions in the Q&A chat. I know many of you have already done so. If we don't get to your questions in time, the media team at the OMA will follow up with you, and you can also email media@oma.org with additional requests for interviews, and we'll also have a recording of this session available later this afternoon. Okay, with that, Ryan, go ahead.
Thank you, Dr. Kassam. The first question is from Maria Soro at the Toronto Star. And it's directed toward Dr. Lowe. Last night, Toronto Public Health recommended schools in the city pause all extracurriculars. Will Peel Public Health do the same?
Ryan, I'm actually going to answer all three questions all together because I think it's probably easier. So did you want to read out the last two, and I'll answer it all together?
Sure. The second question is, we know sports and other activities can support children's mental health after a difficult year. Was it premature of Toronto Public Health to recommend a pause of extracurriculars? And number three, should close contact extracurriculars like sports, basketball, for example, be limited to teenagers who are fully vaccinated?
So thank you very much, Ryan, for reading that. Thank you, Maria, for the questions. At this point in time, Peel Public Health is continuing to monitor the role of extracurriculars and other activities, sport activities within schools, but we're not recommending a pause just based on our current community profile. We do recognize that sports and other activities can support children's mental health. We also do recognize that there's an equity consideration as well, because many children access these activities in the school setting where they may not otherwise be able to access it. Really the question is, if we're allowing some of these extracurriculars and sporting activities to occur outside in the broader community, I think the logic suggests that within the school setting, particularly with safeguards and safety processes in place, it's something that could go ahead, certainly as part of the overall school experience. Recognizing, of course, that if things change, if we start to see data that supports challenges or revisiting of the decision, that we would not hesitate to do so, especially if our community transmission levels increase. But I think the more important thing is really in your third question. We're looking at all the ways to ensure that children can partake and derive the benefits from these activities with as many safety measures in place as possible. And one of the things that we are looking at is whether vaccination status plays into that. We haven't made a decision at this point in time, but this is an ongoing active conversation with our school board partners. We have also recommended at this point in time that people consider limiting the number of extracurriculars and sports that they may engage in to one or two, just sort of starting out gradually as we would with a medication, just really trying to make sure that we take a return slowly, but we will not be, based on our community context, issuing a pause on those activities at this time.
Thank you, Dr. Lowe. The next question is for you as well, from Michelle Molesky at CTV Windsor. You said this year is different. Do you mean because we have vaccines, children and their parents don't have to worry as much if they have an exposure in their cohort?
It's partly that. I think what really makes the difference this year is that we do have a significant proportion of the population that has availed themselves of vaccine. And we know that the best defense to keep COVID out of schools is to keep it under control to some extent in the community, to try to keep transmission levels limited, and then to limit it right at the door through screening, cohorting, et cetera. So I think just on that basis, we're in a situation where it's not the whole population community susceptible as it was previously in our return in fall 2020, but there are opportunities with the vaccinations and the continued vaccination efforts, plus the measures that are in place in schools to hopefully ensure that in-person learning remains safe and that children can derive benefit from that and all the activities that the school has to provide.
Thank you, Dr. Lowe. The next question from Clary Feinstein at the Brampton Guardian. I'll direct that to you as well, Dr. Lowe. With children under 12 unvaccinated and without smaller class sizes, what can be done to ensure the virus doesn't spread rapidly in these settings?
Well, thanks so much for the question, Claire. And I think this makes it very clear, again, first of all, the levels of community transmission will help to limit introductions and will help to limit the spread in the broader community and essentially build a bit of a firewall around schools in that sense. But within the schools, this isn't a return to school fully normal, fully open. As much as we'd like to, do that, we are still in the midst of an active pandemic response. So it is more of a matter of everything that has been put in place, the measures in terms of screening, in terms of cohorting, the masking, the distancing, the ventilation, the rapid testing and the testing take-home kits, the vaccine mandates for staff. I think all of these measures together are really about building a cocoon while we do await further approval of vaccines for those under 12, and while we also work to diligently get vaccination rates up to a tolerable a level that would be tolerable and able to confront the Delta variant around 85 to 90% two-dose coverage. And then, of course, working with everyone to just make sure that we're also reducing some of our discretionary contacts to limit the possibility of infection and broader community transmission.
Thank you, Dr. Lowe. The next question I'll ask Dr. Nasello to answer. I'm hearing young women, teenagers, and those in their 20s are very concerned about COVID vaccine affecting their fertility. Do you know what these concerns are based on and how or what started these concerns?
Well, it is actually untrue. There is no effect of the vaccine on fertility. However, there are a number of other things that can affect women's fertility. And that can be, someone who acquires a sexually transmitted disease that causes scarring of their fallopian tubes. It may be someone that is not ovulating on a regular basis. That's looking at one half of the partnership. The other half of the partnership, we do know that in the last 50 years, sperm counts have actually significantly dropped. And we suspect it's likely due to estrogen type byproducts in our water and our food. Certainly it was quite an issue in the 70s with DDT and 2,4,5-D and I think it was TCDD. The byproducts acted as estrogens in the animals that took it, and of course, eventually are concentrated, and we eat those animals. That's not anything that's going to change soon. The actual contribution from birth control pills being flushed down the toilet is somewhat minimal in comparison to the environmental issues. That's to say that infertility can't be predicted now for the pregnancy you want to attain 20 years in the future. It does not affect menstrual cycles. There are many things that can affect menstrual cycles, and stress can affect it, being ill can affect it. Both things can affect sperm counts on a short-term basis, because our male partners actually take 120 days to make a sperm. And they have to make millions to get one egg pregnant. So there can be a problem at anywhere along the pathway. Unfortunately, the people that have been talking about these things have been using science-y sounding words that actually don't mean anything. And unfortunately, there is a portion of the population that their role in life is to challenge can challenge organized government, organized medicine, organized anything. You know, you have to take a lot of what you hear on social media with a grain of salt. It is very easy to go down a rabbit hole and be somewhere else that you didn't intend. And we all know how easy that can be. And particularly with vaccine information, with the virus information, we have to be very aware of that because the risks of getting COVID at any age group still has the potential of having some major illnesses that remain after the virus is cleared. And, you know, you have to think of what happened with polio. That affected children for years. These vaccines were tested collectively in over 100,000 women before it hit the market. And the polio vaccine was tested in less than 5,000. You know, so you have to, and parents and their children lined up for miles so that their kid could get vaccinated. You know, I'm of the generation where children acquired all of the viral illness of pregnancy, and some became very ill. I had friends that had suffered from polio, and you know that follows them through their life. And then they get a second wave of immune issues developing later in their 50s, and so that's a very difficult thing to manage. And I would hate to see somebody, you know, take alternate medications instead of the real thing that's been tested and followed up in post-marketing studies to be safe, and get something that's going to shorten their life and their quality of life.
Thank you, Dr. Nasello. The next question is from Melissa Kudo at Canadian Press. Thanksgiving is about a month away now. How should we be navigating indoor family gatherings that include vaccinated adults plus unvaccinated children who are now in school and increasing their contacts? Will families need to limit those gatherings at this time? Dr. Kassam, do you want to weigh in on that one? And maybe Dr. Lowe can chime in afterward.
I was actually just going to pass it over to Dr. Lowe for his perspective, but obviously as we're trending to indoor activities, a little bit cooler weather, we know that families want to get together and see folks who perhaps they haven't seen for a very long time. I know that there's an appetite both to eat turkey, but also to see people around a table. So, you know, I think that the natural progression of where we're going with where we're at in terms of our vaccination rates. October, you know, obviously is around the corner. If we can spend the next 4 weeks getting as many people even more fully vaccinated as possible, I think that's going to be really an important step forward. I think that, you know, the current stage that we're in, step 3, it does recommend certain restrictions, at least in the retail sector, but certainly has already had some impact on how individual families feel comfortable enough to get together with each other. And so I think, you know, this is going to be, I think, based on how we see this next fourth wave unfold over the course of the next 4 weeks. Hopefully we'll have much better data and the numbers will support those activities indoors without too many restrictions. But Dr. Lowe, maybe you can give us a little bit more perspective on where you forecast the next month going.
Dr. Kassam, I think you've covered off really a lot of the big points that I was going to make. You know, certainly in October, it's difficult to forecast where we will be, both in respect of all the metrics and the trends that we'd be identifying. But I think the guidance is pretty clear for individuals who are fully vaccinated and you are indoors in a group, either a mixed group or a group with other individuals who are fully vaccinated. You can really consider limiting or consider dispensing with some of the measures. Now the question always becomes, well, what about the unvaccinated children? Where does that fit? And so I think, you know, again, it really is about keeping community transmission levels low, keeping this out of schools, because the reality is that going to school in and of itself is not an exposure. It is about when people actually do show up and they may be sick, they may have slipped past screening, they may have been an asymptomatic infection. That then becomes the bigger issue. So as long as everyone is, you know, sticking to the game plan, which is getting vaccinated if you're eligible, and then making sure that you're limiting discretionary contacts where you can, then there may be opportunities for small family sort of gatherings, depending on what the picture looks like at Thanksgiving indoors.
Thank you, Dr. Lowe. The next question is from Joanna Furketich at The Spectator, and I'll direct that to you, Dr. Lowe. Ontario's Chief Medical Officer of Health said recently that parents of young children are less likely to be vaccinated. Do you know why and what can be done to get past that hesitancy? Hamilton, like many places, have fewer young people vaccinated despite enticements like soccer tickets and watching the Ticats practice. What is the best way to reach young people to get them vaccinated?
So I think the one thing I'd highlight, both in terms of young adults as well as young people, is that there are lots of reasons why people may not have gotten vaccinated just yet. We do know that there certainly is perceptions, and I'm sure Dr. Nasello has spoken to this as well, perceptions around myths and misinformation. There's also perceptions of their own risk assessment. I think it's absolutely vital for people to understand that if you are young, you are still at risk with Delta. We don't. You may very well have high odds or high probabilities of having a mild illness, but we're seeing in the United States, right, in Florida and Texas, throughout the South, young individuals who are actually spending, significant amounts of time in hospital and ICU. So I think it really is about trying to change risk perceptions on the nature of the risk and that people are assuming when it comes to COVID. And then the other thing that we know, especially with parents of young children, is there is a barrier to access in general, just time poverty and challenges with actually being able to get to vaccines, which is why our vaccine program is now shifting to reduce those barriers as much as possible, being out and about in neighborhood stores, in grocery stores, and bus terminals, being where people are at, to really just try to make this as easy and seamless as possible for them to get their questions answered and to get their vaccine.
Thank you, Dr. Lowe. The next question is for Dr. Kassam from Michelle Molesky, CTV Windsor. Does the OMA believe school staff should be forced to get a shot similar to mandatory policies coming to Windsor hospitals?
Yeah, thank you for the question. We've actually been on record to say that both education workers as well as healthcare workers should be vaccinated in those workplace settings. And of course, being physicians on the front lines, in fact, and I'm happy to share, and this is what we've actually collected data on this over the past couple of months, which is that 98% of physicians have been fully vaccinated against COVID with the vaccines. And that's a really remarkable number. And we, as Dr. Lowe has already been describing, want to create this firewall around schools, around other educational institutions. And so this is an opportunity to be able to get to that point with mandating of vaccines in these settings. And we believe that healthcare workers as well as education workers should be vaccinated in their workplace settings.
Thank you, Dr. Kassam. The next question is for Dr. Nasello from Melissa Kudo, Canadian Press. When you mentioned how vaccinated pregnant people pass on antibodies to their babies, is that only when the pregnant person is vaccinated during the pregnancy? If they were to get pregnant a month after their second dose, do antibodies still pass to the baby?
Yes, the antibodies will pass through to the baby. The key is that mother has antibodies in her blood, and those antibodies actually cross the placenta and are delivered to the baby. The other interesting thing in one of the studies I was looking at on breast milk and newborns, someone's actually done a study to show that the highest antibody levels are actually in women who have breastfed for 23 months or more. There aren't a whole lot of people that are able to breastfeed for 2 years. So, but any bit of antibody is going to help, because we all know that this is an inhaled virus, and it can linger in air for significant amounts of time. I think there's still a role for hand washing and surface cleaning, because eventually they will fall to the ground or surfaces. But I think we do have to keep in mind that, like many of the childhood viruses that hit as soon as people start school, this can be spread equally as easily.
Thank you, Dr. Nasello. Next question for Dr. Lowe. When can children under 12 be vaccinated?
Yeah, so it's a great question. I think all of us are awaiting that day, and public health units, as well as our partners across primary care, pharmacy, hospitals. We're all ready to ramp up and get that population vaccinated when it comes available. My best understanding from colleagues is that the studies are wrapping up sometime this month and will be submitted by the pharmaceutical companies to the regulators in the United States and Canada and Europe. And then subsequent to that, following their due diligence and review, hopefully in the next few months, we'll be able to get a decision on that at that point in time, along with indications as identified by NACI as to how and who should be getting vaccinated in the under 12 cohort.
Thank you, Dr. Lowe. The next question is for you again from Joanna Ferketic at The Spectator. Many parents of unvaccinated kids want to know if their child's teachers are vaccinated. How important is it that a teacher of kids under age 12 is vaccinated? And do you think parents have the right to know whether the teacher is vaccinated or not?
I think the broader thing that we should be asking is really how do we ensure that as many people as possible are vaccinated? Because at that point, then it doesn't really matter whether it's less important to know the specific individual, but really just trying to get that coverage here and throughout the community. That said, we also know in the school setting with the masking, with the PPE, the visors, all those other things that may be used, those do provide additional lines of defense for those children under 12 who can't be vaccinated at this point in time. But again, it just speaks to the need to both ensure that schools are complying with the safety measures that have been identified by the protocols and guidance, and that we're trying to get as many people through this last mile of vaccination vaccinated with 2 doses as soon as possible.
Thank you, Dr. Lowe. A follow-up from Joanna Ferketic. The Hamilton Wentworth District School Board has instructed parents and kids that it is inappropriate to ask someone about their vaccination status. What do you think of that advice? What is your advice when it comes to asking others about vaccination status?
Well, I think this is more getting into the realm of social contract and what's in terms of relationships, how people might approach and engage. I think obviously if these are people that you know personally, that you're engaging with in that capacity, you navigate that relationship where it goes. But we do recognize, of course, that when it comes to vaccination status, it can be an issue that is quite divisive and quite challenging to raise. So I think in the absence of a clear mandate or a clear certification program where it needs to be stated, the proactive asking, you would need to weigh that against sort of just the other approaches as you would about asking about anyone else's medical information or conditions. But again, it's one of those sticky areas that I think I'm hopeful that the policy regime will eventually come to sort out as to what places vaccination status will be more easily available and transparent for individuals, and where we will continue to maintain that. But I think again the bigger point is leaving aside individuals. The big thing is about our collective efforts and making sure that we can all try to push towards 90% or above as soon as possible.
Thank you, Dr. Lowe. Next question is for you as well. We've heard a lot about the risk of COVID-19 cases increasing as children return to school. What about workers returning to workplaces, office spaces?
So, I think it's not about COVID-19 risk per se in terms of return to workplaces and office spaces from a severity perspective, especially if people are vaccinated and especially if the workplace is taking their safety policies in place. But again, our best defense is trying to keep community transmission lower. So that's why in the Region Appeal, we made the recommendation just yesterday that people who are able to work from home, at least through this initial period while we're getting schools back in, they continue to try to work from home as much as possible if they can. We recognize, of course, that as more and more people come into contact, the possibility of infections, as well as particularly not uncommon breakthrough infections, is something that we would want to try to minimize as we're trying to keep the community transmission under control and get as many people vaccinated as possible while schools reopen.
Thank you, Dr. Lowe. Next question for you as well. Keeping young children 6 feet apart is almost impossible. Is there anything other than masking and hand washing we can do to keep children safe?
Yeah, I think we've certainly mentioned that you've got the screening, right? You've got the cohorting, which will prevent passage of infections throughout free mixing in the school setting. We certainly have the ventilation improvements, the rapid testing in the event of an exposure. So all of these again are that multiple layer strategy in terms of really trying to keep schools safe, in addition to ensuring that educators are vaccinated in line with provincial directives.
Thank you, Dr. Lowe. And what should we expect if cases significantly increase with a return to school? Or yeah.
So I think we would anticipate that cases are going to continue to increase, because the reality is we are in a fourth wave, and we do have a significant proportion of our community that remains unvaccinated. The bigger question is what we can do about it all together collectively, and that is really ensuring that we all get to 2 doses of vaccine as quickly as possible. And until such time that we get to a more endemic state, making sure that we're still sticking to those precautions. The distancing, the masking, reducing our discretionary contacts, favoring the outdoors, remote work where you can, virtual meetups. Those sort of things continue to be all critical to ensuring a safe return to school and navigating the fourth wave.
Thank you, Dr. Lowe. This is our last question, and it's directed to you. Is there a best type of mask for young children?
At this point in time, we still recommend that the best mask for young children is one that they can wear, right? One that they're comfortable wearing, because we know that they'll benefit from that. If it's not comfortable, if it's not something that they're going to wear, then I think the mask has very little benefit. Beyond that, of course, there's the broader measures in the school setting, in addition to masking, that will hopefully help to augment that as a safety measure.
Thank you, Dr. Lowe. That concludes our media Q&A. I'll pass it over to Dr. Kassam to provide closing remarks.
Thank you so much, Ryan. And first of all, thank you so much, Drs. Lowe and Nasello. Really, your presence here and your knowledge, your wisdom, imparting on all of us, I think, has been extremely valuable. So I want to thank you for taking time out of your days to be here with us and to share with us all of your knowledge. And thank you, everyone else, for attending our briefing today and your thoughtful questions. Obviously, this is a very crucial time for the public and of course, parents and writ large our society. And I hope the session was helpful in informing your reporting. I look forward to watching and reading your coverage. If there is a topic, once again, that you would like to hear from doctors discuss in the future, please send along your suggestions to media@oma.org. Thank you again for your time. Stay safe, stay healthy, and thank you very much.